Let's talk a bit about the coronary calcium score. A calcium score measures the amount of hardened or calcium plaque in the heart's arteries, and this is all part of a process called atherosclerosis, which actually begins quite early in life, around your 20s. To obtain a calcium score, you have to do a CT scan, and in this CT scan, no contrast is required because the calcium shows up as bright white. This essentially grades how much calcium is visible on the CT scan, from no calcification all the way to severe calcification when you get numbers above 400 into the thousands. Soft or uncalcified plaque isn't very visible on CT calcium scan. You can have a calcium score of 0, but on the inside of the arteries there could be significant encroaching soft plaque. And it's important to know that most heart attacks come from these soft plaques, which are more unstable. On the other hand, you could have a relatively high calcium score, but the interior lumen of the arteries can be quite stable with minimal soft plaque. Because we can't properly assess the interior lumen of the artery with a coronary calcium scan, it's not really an accurate live measure of blockage or how much blood is flowing or how well blood is flowing to the heart muscle. To find these things out, you may need a more dynamic study, such as a stress test or a coronary angiogram. This brings us on to a key concept, the negative predictive value. This is the probability that an individual with a negative test result does not have the disease or condition being tested for. An important note is that the negative predictive value of any medical test is influenced by the pre-test probability of a certain patient population having the disease in the first place. Imagine that both of these patients have a low calcium score. Patient 1 is Sam, a physically active 30-year-old. He doesn't smoke, he has a perfect lipid panel, no blood pressure problems, no diabetes. The other patient is Bob. He's a 50-year-old smoker. His LDL is through the roof. He smokes 2 packs of cigarettes a day. He has a significantly raised BMI, and he's had type 2 diabetes for 10 years. The chance of people like Bob, even before we've done any testing, of having significant plaque and atherosclerosis is much higher, and this makes a low calcium score less reassuring. However, at the very least, the presence of coronary artery calcification is evidence that there was prior damage to the endothelium, and it may show a certain predisposition of the coronary arteries to coronary artery disease. In other words, we can see that artery damage has been done and repaired. Around the world, there are some similarities in how the calcium score is being used. It's typically performed in those above the age of 40 with intermediate risk. The American, the Canadian, and the European guidelines broadly use it as a decision aid in prescribing anti-lipid therapy in those of at least intermediate risk. So what is intermediate risk? This is quantified using pooled cohort equations and is defined as having an estimated 10-year risk of atherosclerotic cardiovascular disease of between 7.5% and 19.9%, based on certain risk factors, using your age, your gender, your race, and your lipid panel, as well as your blood pressure, any blood pressure treatment you're on, and if you're diabetic or if you smoke. Now, should the calcium score really change management? Well, in patients who are already high risk, with a sky-high LDL, and all the cardiovascular risk factors you can think of, probably not. These patients should be treated aggressively anyway, to reduce all these modifiable risk factors as much as they can. You can argue that for certain intermediate patients who are really not keen on a statin, a low calcium score might provide the physician and the patient with a bit of reassurance. However, we must remember that the calcium score does not show much about the amount of soft plaque on the interior lumen of the arteries. As we grow older, we will have been exposed to a cumulative amount of cardiovascular risk factors. So it's better to be proactive anyway with aggressive management of dangerous risk factors, especially as the beginning of atherosclerosis has already started in your 20s. Something you might not know is that statins can increase your calcium score, and so can aerobic exercise. However, this is not necessarily a bad thing, as this can stabilize plaques and make them less prone to rupture, with evidence showing that more than 70% of heart attacks come from ruptures of soft unstable plaque. Overall, a calcium score gives us some idea of the late-stage atherosclerosis in someone's coronary arteries. It should be used in conjunction with existing risk calculators. It should by no means be used to rule out cardiovascular disease in those of high risk with traditional risk factors, due to its lack of sensitivity in detecting soft plaque. As always, if you have concerns about your heart health, you should talk to your doctor or your cardiologist. Thank you for watching and stay tuned for the next video.